Morning.
Hey, good
Good
morning.
morning. This is Erin with the Department of Medicaid. It is not quite 10 o'clock and we're still clearing out the waiting room, so we'll give it just a few moments before we get started.
Okay, thanks.
Erin, I think it's 10 o'clock. Do you think everyone is on from your side?
I believe so. We still have a few people kind of trickling in, but it is 10:01. So if you would like to go ahead and get started, I'll turn it over to you.
Well, if we have a few people, we can wait a couple of minutes.
Okay.
Yeah, I'm fine to give people a couple of minutes.
It looks like the waiting room is cleared. I do want to mention Veronica will be with us. She's just going to be a little bit late. I wasn't sure if you saw her email she sent out.
Thank you very much. So I'll go ahead and call this meeting to order. Good morning, everyone. And this is our last TAC meeting with our current slate. Barry Martin has been elected as the new chair for the Kentucky Primary Care Association, and will be establishing a new TAC committee. So Brandon is here, Barry is here. I don't see Dennis. Dennis hasn't joined, correct?
I see Dennis.
Believe he was logging in a little, he was just now coming in, so he may just be getting into the meeting.
Good morning, Dennis. So I think that establishes our quorum. So moving on to the approval of the minutes, is there a motion to approve the minutes that were emailed?
So moved. This is Barry.
Thanks, Barry. Is there a second?
Second, this is Brandon.
Thank you, Brandon. All in favor, aye.
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 Thank you. So moving on to old business, if Veronica is going to be a few minutes late, should we defer that piece?
Yes, if you don't mind.
Sure. Okay, so we'll skip down. Is the DPH representative on this morning?
I don't believe we were able to get someone this morning, so I apologize on that.
Okay. And what about DBHDID?
Give me just a moment to scroll. I apologize. I'm not seeing anyone logged in currently. I know several people did accept the invitation, but I can keep an eye out for someone as they pop in.
Okay. Well, we'll skip down to the PCA and updates from the PCA and the CIN. Except that I'm also not seeing Dr. Hoagland's.
I'm here, Stephanie. Dr. Hoagland's kind of juggling two different meetings, so I'm here.
Hey, good morning, Molly.
Hi, how are you?
Good.
So do you want me to take this, Stephanie?
Yes, please.
Okay, sure. So we were a couple things. One is with respect to school-based clinics, it was the issue was raised and introduced last time about well child visits and immunizations, and then just different outreach and ways to deliver preventative and well care to children. And we thought that it would be relevant to bring up and raise attention to the discussion that has started about school-based clinics. As you all know, that there's two different types of services. There's the school nurse feature from that has to do with the Department of Education and providing resources and accommodations for children in the school setting and with IEPs. And then there's also the school-based health center, or the kind of more comprehensive health center model that is developed and offered either by a federally qualified health center or a rural health clinic in a in a school setting. And so there are several members of this TAC are offering those services, and they can share about how they're offered. But I think it's helpful to bring attention to the differences between those two types of services, and how children who are on Medicaid are being cared for, or like kind of what the resources are and how they're coordinated. That's provider type 21, that is the school nurse provider type, is different and than what the school-based health center is able to do. And so we would like to be able to be engaged in those conversations about what the opportunities are. We understand that it has a lot of coordination is required between the local school and the community, and just how the services are rendered and billed and the consent from the parents. But wanted to bring attention to the fact that a lot of those services are offered by the primary care providers that are represented through this TAC. And then Barry, does anybody want to add to that? And some of the hurdles that you all are encountering.
Sure, Molly, I'll jump in. We have a school-based site at Berea Community, which is a K through 12. We have behavioral health and a nurse there every day. When we first started, we had staffed a nurse practitioner at that location in an attempt to have enough billable visits to sustain the school-based model, and sort of what we call those boo-boos and band-aids kinds of visits that are non-reimbursable to FQHCs and rural health clinics. What we found was that the volume of that made it virtually impossible for her to also conduct billable visits. So we transitioned to staffing that with an RN, and then linked to one of our existing clinics via telehealth if we need to do a billable visit. But we really discovered that we need to have sort of two pathways and two rooms going. So this year we're now, we have kind of two exam rooms, if you will, so that we can do sort of the daily boo-boos and band-aids, working with diabetic students to adjust their insulin after lunch and sort of those like non-reimbursable things. And then in the second exam room, if a child does need a billable visit, then that happens via telehealth in the other exam room. Additionally, we have LCSWs working in the school, and then we have a mobile dental unit that goes to Berea Community regularly, as well as a number of other community schools in our community. But I do think that, the inability, the school doesn't have the bandwidth and the budget to hire the nurse, which is why they oftentimes look for a partner. But it's been our experience that it's really difficult to break even on a school-based clinic when you're doing all of this work that ties up your healthcare provider that's non-reimbursable. So like I said, we're trying something different this year, but it very much is our concern that if we can't find a way to make that program more viable, that we will have to look at changing our model completely. Dennis, Barry, Brandon, Patrick, John, I see you guys on there. Are any of you doing school-based health, and what's your model in your experience?
We don't have school base here.
This is Barry. We've had it for about 12, 13 years, and we started out with the nurses in the schools, and then we kind of evolved to what we call an EduHealth program, where a nurse practitioner or PA is at the clinic, and the nurses correlate that with them whenever it triggers a visit caliber. And so we kind of do the same thing, but a lot of the services, I mean, and that's why the health departments had to get out of it, was because a lot of the services that they provide, it's being more and more borne on the school nurse, and it's not a billable service, especially under RAC or FQHC rules. The nurse visit is not billable. So that does cause some problems, financial constraints.
Patrick, you're in schools, right?
Yeah, I guess I am. Can I have a question one more time? I'm sorry, I've been on the road.
We were just discussing members of the TAC that offer school-based health centers.
Yep.
As or are in relationship with the school nurse program, and the balance of that, because you all are a different provider type than that provider type 21 nurse that's able to bill in a different capacity and has a different scope.
Right.
But the services that you're able to offer require a different layer of coordination with the school, and also additional resources and professionals.
Yeah, absolutely. So we've had school based now for about 4 years. We were very lucky to accept school based funding for the start of that. So we initially started up during COVID. The majority of our visits initially, honestly, were collaborating with the schools and trying to figure out, how to have that point of care testing so we could get kiddos and staff in the schools, try to keep them healthy and work in conjunction with the schools. We started out with utilizing MAs or LPNs in the schools in conjunction with telehealth services with our providers inside of our main sites. And we were using telehealth options. Then we grew, and the services were utilized to a pretty great capacity. So just pretty much initially the first year, we're just acutes and COVID testing, but we were trying to transition that to primary care. So we staffed up and put an MP, a dedicated MP inside of our schools. So we have one MP inside of 5 schools. And we have MAs in every school too, and that MP has the ability to rotate. And one of the challenges we've had is really defining and working with the school system and having clarity on the separation of duties between what the schools do from a liability standpoint, the Kentucky Department of Education, and what our role is within the schools. It's definitely been a challenge, but our school system had never had healthcare in the school systems up until we stepped in. So one of the biggest challenges for us was just creating that culture and making sure that we collaborate together. From a billing standpoint, we're about 80% Medicaid inside of our school system. So we've been able to be pretty profitable up to this point, and we see a decent amount of volume. But it doesn't take a tremendous amount of volume to break even. And we've always ran it as like a no cost to the school model.
And Molly, I think that that's a great illustration, because if you can really just provide the like the actual visit services that the student needs, and that's really important, because a lot of students, like, their families aren't able to get them to care, or they get them to inconsistent care, or particularly we see with oral health that they just go without, that you don't have to have a lot of volume, and it's an important service in the school that I think we're all committed to. But if the school is also looking to you to do the day-to-day traditional school nurse pieces, it's really difficult to do.
Stephanie, can I kind of piggyback on what you just said?
Yeah.
Yeah, Stephanie's exactly right. So we actually worked with our school district to come up with a new contract for this school year. And what happened was we started tracking, we call them kid care touches. It was how many times we touch kids for boo-boos and band-aids and chapstick and sunscreen and just everything that you could imagine. And what we were seeing was 75% of our daily visits were based around non-billable visits. Okay. And what we went to the school and told them is we want to stay in the schools. We want it to be viable, but also too, we live in a very impoverished community, and our schools honestly cannot afford to pay us to have healthcare in our school systems. So it's how do we advocate for our children and give them access to that care without, you know, and from a liability standpoint, like I can't afford to put an MP in every school, and I have to figure out how to stretch resources as far as possible. So one of the challenges for us was, all right, well, here's what we know, here's the needs and stuff like that. But what we noticed was the schools were passing a lot of stuff off to our girls inside of the school district and allowing them to do a lot of stuff that were really outside of their scope of like handing out chapstick and stuff that the front staff and you know other staff within the schools, the youth resource service center and stuff were doing before we got there. We just become kind of a dump site, and they would just give us all these little things and ice packs, and we would do all this stuff. And it got to where it was interfering with us doing med dispensing or any of the basic necessities that the kids actually needed. So yeah, Stephanie, I would agree 100%. I think figuring out how to collaborate and have the schools do their fair share, so that we can actually do the job that we need to do.
Well, the problem is the schools don't have the financial resources to put nurses in themselves. The health departments used to do it, but then I think their reimbursement kind of went away, and so there's nobody else to really do that, except for us.
Yeah, and there's a real
Yep.
value to the parents, to the school system, to be able to meet the students' needs there and be able to kind of triage and respond.
When overall it helps attendance. It helps attendance with
Right.
the kids. It helps attendance with the workers, the teachers and the staff. They also use the service, so it's so beneficial. Our superintendent would say that it's crucial to keep the service, but it hinges on the backs of the healthcare providers, not actually the schools.
Yeah. So, and then also the needs, the behavioral health needs of the students as well. Are you all providing behavioral health support as well?
We are.
Molly, this is Patrick. We are not, but for the sheer fact that we don't do dental or behavioral in the schools, even though we offer behavioral at all of our other sites. They have a great relationship with Life Skills, and they have a lot of staff that are on site daily, so we collaborate with them. And then dental, the current health department have had a long-standing contract for about a decade with the school system and offer dental services.
One of the things that we saw was that some of that in our community project, the health department would do some of the hygiene, like apply fluoride and stuff like that. But particularly as students got older in middle school and high school, they needed dental treatment. So, you know,
Sure.
we were getting calls from people who, you know, I've got this 16-year-old who's trying to sit in Spanish class, who their face is swollen and they're in such pain. Can you get them in? And so it has been wildly successful to take our mobile unit to the schools, and it's been really exciting to hear from students, to hear the students express how much they value that service. We've been doing behavioral health since we started at Berea, probably 10 or 12 years ago. And again, it's a little bit of a different kind of dynamic, but similar in the sense that what we've seen is that the school also, they need somebody doing traditional therapy, but they also need somebody functioning more in that behavioral health consultant role, managing the crises that come up during the day. So, you know, kids with various different behavioral health diagnoses have symptoms that disrupt classrooms, and so, or they will want to, the teacher will want to consult with the LCSW to say, I have this student in my class, how can I best support them? And so, you know, it would be really difficult sometimes because teachers would want to walk in while she was in a session. And so we really had to do some reminders to say, we're glad to provide some consultation, but that has to happen outside of our visits with kids because the kids are gonna come first. But yeah, Molly, I think that I could probably put 5 therapists in even just Berea and they would stay busy.
So to
Yeah.
summarize, I think that what has been said and the reason why this is on the agenda is because with Kentucky's with commitment to improving the health of children, schools are an awesome access point in terms of the fact that children go to school. There's doors that are wide enough, or ramps, there are interpreters, there's you don't have childcare concerns, there's buses, so transportation isn't there's when children go to school, we're trending in the right direction. And that primary care providers are an important part of being able to care for children when they're at school and be able to help them stay in school. And so as the Department for Medicaid Services and the Department for Public Health look at ways to coordinate programming to support the health of children, we would like to invite or to request inclusion of those conversations, because what you all have been able to work at a local level in coordination with the school nurse as distinct and apart from, or perhaps as a delegated, or however the arrangement seems to differ from one location to the other based on the kind of the community needs, that what is able to be provided in a school health clinic is of tremendous value. And we would like to be able to be a part of the conversation of what's necessary in order to sustain that and improve, the viability of that operation, because it sounds like you all have had to be pretty creative in how to make it work. But at the same time, you're asked to come do it because the other entities haven't been able to make it work. And so we're committed to this cause, but we think that with some coordination of resources and programs, we can, be better stewards of public funding and the ways that the operations work.
Thank you, Molly. Are you going to talk about the TAC changes as well, or is Barry going to do that?
Barry, would you like to do that? So
Talk about what?
I'll just tee it up. I'll tee it up for a second that, as you all know, by statute, we have the primary care TAC. The KPCA is able to facilitate this forum, and we really appreciate and are grateful for that opportunity. And it's something that our members really value. And so it is something that as a nonprofit, we have a board of directors that reflects our membership, and the TAC is an important part of being an advocate for the stakeholder group. And so Barry, we're excited to have as our incoming chair. Stephanie, we're so grateful for your work over the past 2 years. And so it's kind of at the end of this meeting, we'll have the passing of the torch for the TAC, and Barry is working to construct the next group of 5 representatives. Barry?
Yes. The next chair of the TAC will be John Lillybridge, and he's on the call. And Patrick will stay on there, and Dennis Fouch will be joining us. Brandon will be still staying on there, and myself. And I think that's the group of 5 on the TAC. The upcoming.
Sorry, this is Erin. Do you mind to run that? I've got John, you, Dennis, and Brandon. Did I miss?
Patrick Merritt.
Patrick, thank you. Well, welcome, John, and Patrick, and everyone else staying. Stephanie, thank you very much. Barry, I may reach out to you just to confirm I have everyone's correct contact and email address after this meeting.
Okay, sounds good. I can send that to you.
Molly, are you also going to do the update from the CIN in Dr. Hoagland's absence?
Happy to. So I think currently the last count I saw is that our CIN has about about 500,000 lives, about 350,000 Medicaid lives covered through almost 90 of our members are able to collectively come together and coordinate services in order to work pursuant to the contracts that we have with all 6 MCOs, a couple commercial plans and Medicare Advantage plans that currently we are working to work with our payer partners to reach those quality goals that were set by the Department for Medicaid Services. And with the investment and implementation of a population health tool, we are seeing increases in the number of immunizations, and well visits, the use of or kind of helping to work on pre-visit planning in order to do the preventative care services, and are really thrilled with the data that's coming in and that the work our members are able to do in terms of creating not only scheduling and creating access to their services, but also being able to get those records, in a way to the payer so that's recognized, which, as you all know, is harder to do than it seems. So we are coming up on the end of the year and working together with the payers to kind of for the year end or year closing, and then also looking ahead for the next year. And I'm not sure if Veronica was able to sign on, but we were interested in knowing more about what the quality measures and the quality plan will look like for Medicaid for next year.
Thank you. I think I saw in the chat that Veronica has joined, so we can kind of jump back up. But I think, Angie, you had said you could kind of speak to that value-based program. So does that include also the measures for next year? And if so, maybe we just transition to that piece now.
Sure. Yes. I am Angie Parker. I'm the Director of Quality and Population Health with the Department for Medicaid Services. The MCO value-based program, if you are not familiar with it, I do have a few slides on that, if you'd like me to share.
I think most of us are familiar with it, but if there were changes for next year, then we would be glad to see this.
There are no changes for next year. It is an ongoing value-based purchasing program as of right now, unless there are challenges or issues with the current HEDIS measures. There may be some slight changes, but there are no changes at this point, other than for 2024, HPV was just report only, and it will be measured next year.
What about the social needs, Angie?
It will also be measured next year. It's a report only for this year. And we understand there's been challenges in getting that data because of the providers not always billing via a Z code or the LOINC codes. But we will be evaluating that. We won't have 2024 data until next spring. Because there's, you have the measurement year and the following year. And so we won't have all those results until later in 2025.
Do you know if there has been any sort of billing guidance given related to the LOINC codes for the social determinants? I know that, we do social determinant screening on all patients annually. And we will add some of the diagnosis codes related to food insecurity, but those are not LOINC codes. And so we have been a little unclear if it's an either or if only LOINC codes are included for that measure. And if so, is there any specific billing guidance around that?
I'll have to defer to Justin Derringer, who is in our healthcare policy division, the director of that. As far as billing, obviously I do believe the MCOs are working with the providers, ensuring that these the SDOH codes are being billed when identified. But Justin, I don't know if you have any input or regarding the LOANC codes at this point.
Not currently. We've got a group of those codes that we're looking at as far as reimbursement, and we've actually got a project going on right now where we're looking at all of those codes in general. So we have a large listing. There are a lot of new codes that have come out this year, and so we have those with everything else that's on our fee schedule currently, and we're looking at how those codes are currently being reimbursed by HMCO, by fee for service, whether they're on our fee schedules or not. And in the same vein, we've also got a part of that project, which is reviewing other states and seeing how those codes are being paid, or if they're being covered by other states, and what their reimbursement rates are for those codes and how they're being utilized. And then a separate piece of that is we've also got a group looking at private insurance throughout the United States and how they are utilizing those codes and functions, and what percentage they're being reimbursed by. So it's all kind of a part of a bigger project that we're looking at. So as a whole, I don't have a lot of information until that project is complete. That project should be complete. We're hoping before Christmas. So that'll be done, put together in a kind of a presentation format and a decision memo. But there'll probably be 4 or 5 different ways we could go decision wise with the final results of that, just based on the sheer number of those codes and which ones to add and what their reimbursement rates will be and how those are utilized. And so we'll send that to leadership, and we'll should have answers and responses back on exactly how those are going to be utilized, how those are utilized now, all those different things, first part of 2025.
Okay. Thank you. I think that that's the key really for us, is when, if we're going to begin being measured on something, on January 1st, then we need that early in the year so that we can get our IT infrastructure aligned, to do that. So,
that will be that will be when I say that, I don't mean we're implementing something the first. I mean that where we're going to move with that should be ready toward the first part of the year. Providers will be given plenty of time to review that, give feedback, get some information from our shared partners in that.
I would say, regardless of how that goes, as far as the review, the expectation would be for any provider, if these social determinants of health are identified, that they are billed. I mean, not necessarily billed, but the diagnosis code should be there so that it helps us and you identify any areas that we need to focus on a little bit more, and just kind of get a better idea of how this is affecting your overall health with the social determinants of health. So it's very beneficial for lots of different reasons to ensure that providers are billing this consistently and asking those questions.
Good morning. This is Veronica Judy Cecil with Medicaid. Just to add a fine point to that is definitely that. Thank you for kind of flagging that, and it makes total sense that providers need the information to be able to be part of the collaboration that's happening around this. It is our expectation for managed care organizations to do that communication around, especially around the metrics that they're going to be held accountable to, on working with providers on making sure that we're getting the data, the information, the claims that support that, so that we can properly measure. So, but a takeaway from here is we'll talk internally about, what can the department do to bring especially consistency across the plans and education to providers, and see what we can do more about educating the SDOH coverage.
Yeah, I think there have been times, currently we're adding it just as like I said, as a diagnosis to claims. I think that there have been times that plans have requested us log into a separate portal and like that is not feasible or sustainable or realistic. To ask a care team to double entry, you know, particularly if you're using like a prepared survey instrument, that's not 5 questions, it's a number of questions. And so, you know, I think that we need to be mindful that we don't create additional burden for care teams, when they're already pretty busy.
Agree.
Yeah, that's a good takeaway. And Angie, maybe, you know, we can talk to the MCOs about how do we reduce the administrative burden.
So Veronica, if you are ready, we will jump back up to old business. Any updates on PHE wind down, redetermination? And
Yeah, absolutely. I've just got a quick slide. I won't take too much time for this, but let me share my screen. Just to give an update on the most recent renewals. So just to let everybody know, we have come out of the public health emergency unwinding for renewals. We've completed them all. So that first, you know, we expanded it to 14 months. We took 14 months to process those renewals because we wanted to make sure that our workforce could handle the workers could handle not only the renewals, but applications and other things that happen with the Department of Community-Based Services for eligibility determinations and redeterminations. So we took 14 months, but we are now out of that unwinding period for renewals and have moved just right into kind of normal renewal processing. So you're going to see, you know, our flexibilities are still applicable that we've applied to the renewals, and that goes through June of 2025. CMS extended those for states, and we're going to take advantage of those, continue to take advantage of those. You know, so you'll still see their extended population. Just a reminder, the extended population, those flexibilities are 1 month for anyone who didn't respond to a renewal notice. We can give them an additional month of eligibility and try to do additional outreach to get them to respond. And for long-term care and 1915C waiver members, they can get up to 3 months additional time to respond and maintain their eligibility. So what you're looking at here is just the most recent months. Of course, we haven't completed October yet. So September is the last month that we've completed. We had 52,369 individuals who went through renewal. 45,833 of those were approved. That's a nice high number. We're always happy to see, especially because we want to really prevent administrative terminations. They're called procedural terminations, where somebody didn't respond. And so we had no choice but to terminate them because they didn't respond. So in the termination bucket is 1,234. The pending column is just a reminder for those folks that they came up on their renewal date. They actually responded, but the state didn't have an opportunity to process that. And so it was pending as it crossed over the renewal date. Those individuals maintain eligibility until the state processes the information. And then extended from the September renewals is 5,301. So those are folks that are in either that 1 month or they may be in somewhere starting their up to 3 months of extensions. That last far right column, we're still tracking reinstatements. We'll continue to do that even though we've come out of the unwinding renewals. And so reinstatements for September is 189. Those are folks that we're tracking in that 90-day period following their termination. If they didn't respond to a notice, they can provide the information. We determine them eligible. We can reinstate them automatically up to 90 days back to the renewal. That's important for providers to understand. So if somebody comes in, they just were terminated because they didn't know or didn't respond to an active renewal, that renewal notice requesting information, if they do that and they're eligible, we could cover those services and reinstate them. So we're still reminding providers that, you know, if you have somebody come in and you can see that their redetermination date just passed or they're within that 90-day period, encouraging them to contact us through Connect. you know, we'd still like to make that determination. It's always better if we can determine somebody ineligible, because at that point, if they're ineligible for Medicaid, we might be able to connect them to a qualified health plan. Speaking of qualified health plan, sorry about that. Just wanted to mention as we're talking about renewals, that the state marketplace for qualified health plans, Connect, the Health Benefit Exchange, open enrollment is coming up November 1. So Medicaid is a continuous open enrollment. Like if you're eligible, you're in. You can become eligible at any time. You can enroll at any time. The qualified health plan is a little different. There is an actual open enrollment period. So it's only during that time you can change your plan. And maybe enroll, especially if you don't have a qualifying event that would allow you to enroll at a different time. So open enrollment is really important for qualified health plans, understanding that it's the only time you can change your plan or maybe enroll. So just letting folks know that that's coming up. We already posted the pre-screening tool on our website. So if you have folks coming in, they don't have coverage, they might not qualify for Medicaid, you know, if you could please encourage them to go out and seek other coverage. We're trying to keep our uninsured rate really low. So yeah, I've got some other new information for you guys, but that kind of concludes the information I had for the renewals. To take any questions.
Hearing no questions on redetermination, is there any new information on RAP reconciliation?
And so for Justin, are you prepared to give a little?
Sure. Yeah, we don't have a lot new going on. As you all know, the RAP work group is still continuing their work. They're still meeting and going through issues and resolving issues. So I think it's going very well. We sent out a RAP FAQ, which I think will be very beneficial. We're working currently on dental crossover claims and getting those clarified, more clarification on that. Crossover claims, dual eligible claims in general, more clarification and resolving issues on retroactive payments and recoupments, and working on our bypass list. And so I think, you know, in the interim of those meetings, we're getting a lot of that stuff taken care of and tweaked, so that in our FAQ document and in our document that we send out to providers, that we can clarify any problems or issues. And then with the RAP work group, it's something that's going to kind of be ongoing, to where any one-offs that occur, we can take care of those as they come up. So I think so far it's been very successful, and we're taking care of and resolving a lot of those problems and issues that providers have had.
Yeah, Justin, I have to say that we're not experiencing as many problems as we were in the past. So it's definitely a breath of fresh air to have this kind of collaboration and teamwork to make sure that we head off these issues. I mean, I don't know if Dennis and Stephanie and John and Brandon, have you guys, is your organization's experiencing any problems with, you know, the wraparound process?
We're not currently.
Yeah, neither
I
are
don't
we.
want to jinx anything, but I just thought I'd ask.
Yeah, same here. For us, we seem to be fairly smooth right now. You can kind of hold our breath. So
We do a lot of dental, so you know, some of those dental problems that are getting worked out are still impacting us, but it's definitely better. You know, I still think the elephant in the room is a lot of those older claims, and you know, I'm not going to be on the TAC anymore, but Barry, I'll probably send you regular emails to ask that we continue to keep that part of the conversation. Because I think that there are lots of older claims and we have earned that RAP money, and there needs to be a process for us to receive that. And I don't know that the process can be a 1-by-1 claim, you know, for nearly 10 years worth of backdate when there wasn't a process for us to do ongoing during that time. So I hope that that continues to be part of the conversation and we come to a resolution that's fair for both the provider and DMS. And, you know, certainly we want to find a resolution that's compliant with federal regulations as well, but we need to talk about what reality looks like.
Veronica, I thought we have addressed that, or hasn't DMS addressed that for providers one-on-one?
So I think, and Stephanie, we can work with you specifically. I think our advice or communication on that was that to work through the MCOs, because the issue is that there is, you know, the encounter did not come into our system, and we can't pay a wrap on something that's not in our system. So, but Stephanie, you know, that's where we want to come in on a individual provider level, that if you're having trouble with working with the MCOs on that, and trying to really identify and then reconcile that, you know, we're happy to try to assist with that, but we do have to, it has to go through the MCO for us to be able to pay the wrap on it.
And just to kind of add just a little bit, when you said, and I do know it's difficult when I say on one-on-one basis on some of the different things, but each provider is so different in some of those past claims and billing and their own contracts with MCOs. And so it's so individualized that we've been working a lot with different providers on individualized cases and past claims and trying to get those resolved and rectified. So, and it does take a little more time, but it is specialized. Each individual provider has that, you know, those unique differences that we do have to look on it that way, kind of as a case by case basis.
Okay, because I did think what we left this as is, you know, we would get things streamlined from a certain point forward. Once we got that streamlined, then people like Stephanie that's having individual problems, if they're showing that the MCOs or what they've done with the MCOs are not clear and not going through, that's when you guys would step in and kind of help with the process. So, I mean, definitely, we talked about this. We can't help from an overall standpoint from that angle, but there is a process in place for each organization to work through the MCOs, then come to DMS for assistance, right?
Yep, that's correct.
Okay.
Yeah, so Stephanie, happy to continue to work through your specific case, and please share that with providers. I mean, if there are other providers that have past claims that they're struggling going through the MCO and trying to work through the MCO, that they definitely should reach out to us.
Yeah, Molly, maybe we can send that out from an organizational standpoint.
Yeah, and I'll post again the email address that, you know, we really prefer providers to work through, so that, because that email box is several staff have access to that, so we can make sure that those things are being addressed and responded to.
Veronica, if you'd like, in our follow-up email, we can add that along with the dispute forms.
Yeah, that'd be great.
Okay, thanks. Once again, thanks to DMS for helping us get this lined out from this point on as well.
Stephanie, you're muted.
So I just said, moving on to new business, we talked about the value-based program. Were there any updates on the utilization trends?
Angie, were you looking at that?
I guess my question is, what specifically are you wanting to know about utilization trends? Are you wanting to know what we're seeing as far as cost and utilization?
I think that, and Dr. Hoagland had led a good part of this conversation previously, but, you know, who is using services, what services are being utilized, you know, who is not using their services and where are they? All of those kinds of things. Are people only utilizing, you know, what percent? I would be interested in, you know, how many members are only using emergent care and are not, you know, seeking primary care. Those, you know, sorts of trends that we can collaborate on to, you know, get people into the settings of care that we want them to.
It would be very helpful if you could supply us a specific list of what you wanted to look at, and we can certainly pull those reports and report on it.
Okay.
If you want to send that to Aaron, and then we can look at it, what you want to specifically address, and then we do have lots of reports, and, you know, we just want to make sure that we are addressing what you are wanting to see and hear.
Molly, can you please share that with Dr. Hoagland? Because I know that he had sort of had a list that we had talked about over time.
We had
Yes.
provided some information a while ago, and there was some clarification on some areas that we needed to get some additional information. It needs to be pretty specific on what you're requesting so that we can make sure that we are able, number one, to gather what you are wanting or needing and then address that. I'm more than happy to pull that information for you.
You know, Molly had mentioned earlier that, you know, we're really pressing DMS and MCOs, and the providers are really pressing the need for, you know, for well child checks and immunizations and other quality measures for our patient population. I want to impress on the MCOs and DMS to help us with these the incentive programs that the MCOs offer. Those are very hard for the patients to access. It doesn't make sense in offering them if you can't access it.
Like the value bait, you like getting an incentive to get their immunization or coming in for a well child visit. Yes.
Yes. There has to be an easier process, or a more streamlined, more patient-friendly process. There's nothing patient-friendly about it.
We've identified that there are some challenges in persons being able to access those rewards. Obviously, it's also an onus on the MCOs for them to be able to get those, because they are being measured on it as well.
Right. I just want to keep that at the
we can
forefront.
certainly obviously address that and see if there's many improvements in that.
I agree. Barry, as you're saying, we would be interested in knowing how from the MCOs, like utilization or of those value adds, and maybe starting the conversation of how to rethink that. It takes a lot of work and effort from a health center to help connect their patient with the value add that, you know, is achieved through the service. And it also, to be honest, creates some equity issues when the child whose parents, you know, and with the assistance of the provider, end up with the Nike shoes because they got their vaccine. And then the kid at school is like, how'd you get those new shoes? And they're like, well, I give well care. And then they're like, well, I have, you know, Acme, and my mom got a car seat, you know, like I want shoes too. So it just creates a lot of confusion, and a little bit with having so many MCOs. Not only is it take a tremendous amount of effort in order to access the value add, but the variety of products, it creates a lot of confusion in what is available to each patient, and then also just kind of exponentially increases the amount of work so that the CHW, whoever is at the clinic, helping them to access it, you know, to know all of the different ones. So we would encourage some consideration of creating easier access and also some more standardization so that they can be more effective and more known.
We do have a value add side by side. Are you familiar with that? That each side by side of each MCO and what value added benefits that they offer. And we are actually updating that for 2025 now.
And actually, I think that side by side really highlights the fact that they are all very different. And that's 6 different portals or apps that have to be accessed in order to get it. So I think that's exactly what we're talking about. It's also what the connectors use in helping somebody who is eligible for Medicaid and deciding which plan to go with. Those are available to them and how they are decided upon, but circumstances change, people's plans change. There's lots of churn. And I think if you asked how many of those car seats, tennis shoes, gas cards are actually accessed, we would be surprised at how at the
we do
at
have
the
that
number.
information. Just FYI,
Yeah,
we do get
if you could
reports on the
share that
value-added
next time,
benefits.
it would be really helpful next time for that to be shared. What is the process to access it? How cumbersome is it? And how often are those by MCO accessed?
Andrew,
Throw
one
this out there. Oh, I'm sorry.
as you update that side by side sheet, one of the things that makes it much more practical in clinic that we had one of our managers do was go back and create a column on the left to have rows by benefit, so that like here is the row for well child visits, here's the row for benefits to pregnant mothers, here's the row to benefits related to diabetics, related to weight loss or food insecurity or whatever. Because it's, to Molly's point, it's such a variable list. And it looks really great. Oh, you can get a Weight Watchers membership with this MCO, but it's actually only for this tiny subpopulation. So that ended up making like that additional layer of detail made it much more practical for use in clinic. So just a suggestion as you update it for 24.
Noted. We'll try to make it easier, but it is a challenge when you, to your point, if for the example you used, if they're only eligible for Weight Watchers for a certain thing, part of that is to drive that person to kind of look on their website to see what all that involves. It is challenging to put, even on 2 pieces of paper, just to have that side by side to give all the details of what those value added benefits are about. But I understand the challenge with that. We might be able to help with that a little bit more.
What about different side by sides? Like have one for well child and then a separate one for maternity, a third one for disease specific. I know that's different pieces of paper, but still it's all the information you need for that one person to look at. I don't know.
Yeah, I think that even would be more helpful, because then you can give it to the appropriate team. The pediatric team doesn't necessarily need to know the maternal health benefit, because likely that mom has already aged out of that benefit.
It might be of a benefit to have each MCO discuss what their value added benefits and how they can access at this meeting. For you to get it directly from them. I mean, certainly do not mind supplying. I can give you the report on what we are receiving on the utilization of the value added benefits, but I think it might be better to come directly from the MCOs on what their value added benefit program is, how it's set up, how it's used, and potentially address the access issue with them specifically. I mean, we can assist with that too, but I think it might be helpful for you all to hear that from them as well. We can address some of this on the back end of things, but just to kind of hear more about what their value added benefit program is like. Obviously that's up to you all. That's just a suggestion.
I think that we had done that at one of the meetings, either earlier this year or late last year. But, you know, I think for all of the NCOs on the call, you know, any sort of alignment that they can create with each other, you know, would certainly be, you know, valuable from our perspective in terms of supporting patients and utilizing those benefits.
Okay.
We didn't have anybody from DPH. Is there a DBH BID update?
I did not see someone join. I will make sure, as we set the 2025 calendar dates, that they are aware. They may just have had a conflict and did not reach out.
So I think by my assessment, we've covered all of the items under old business or new business. Is there any other business from committee members today? Veronica, I think that you said you had a slide about some changes to the map that you wanted to review.
Yeah, if that's okay, I don't want to keep
Absolutely.
you too long, but I think it's good information. Let me, Aaron, let me share. See here. Just a couple of things, and we're trying to talk more about this, and you're probably going to hear us talk a lot more about it as we move into 2025. And that is there were a bunch of federal rules that came out over kind of the last 6 months to a year that impact Medicaid. And so we have been here, this is the list of 9. I'm not going to go into every one of these, just to let you kind of, again, we're just trying to let folks know what's happening and that there will be some changes on the horizon. They have varying deadlines. In fact, just a few have taken effect, but they don't really impact this work or providers directly. Most start next year. They go all the way up until 2030. So you know, there's quite a length of time that will happen for some of these. We are identifying currently the requirements for each and the impact to the Medicaid program. In particular, each provider, you know, they may impact provider types differently depending on the requirement. So we're going to be presenting more and more as we do that identification and development of our implementation plan. We really want folks to be at the table with us. This is not us, you know, just deciding everything and then implementing. We really want input from providers, from members, from advocates on how we move forward in this. But the one I really wanted to talk about was there are some changes, and these are actually effective July next year. So we've been starting to work on this, and it relates to the Medicaid Advisory Council and the creation of a new Beneficiary Advisory Council. So some states already have what's called a BAC, a Beneficiary Advisory Council, but the federal law now requires every state to have one. And then the final rule changes also impact the makeup of the Medicaid Advisory Committee. So Kentucky will need to make some changes to comply. We're talking about this, though, what's important to understand is that, you know, each state is a little different. There are base requirements that every state has to comply with, and then states can have some discretion. For example, the additional composition of the MAC. And so, you know, so we'll have some decisions that are Kentucky specific that we'll need to make. But our MAC and our TACs are in state statute. And so in order to be compliant, we really need to be thinking about what are the changes to those statutory requirements at the state that will put us in compliance with the federal law. They really, I think the goal of this was to bring some consistency across the states in how they handle their Medicaid Advisory Committee and then the creation of the Beneficiary Advisory Council. So there will be some consistency still across the states. I'm not going to go into this a whole lot. We'll share these slides with you all, but this just sort of talks about what those sort of minimum requirements that the states are going to have to make. On the left side are the MAC changes, and on the right side are the new Beneficiary Advisory Council that we're going to have to work on. All of this, again, is just making sure that the MAC and the TACs understand that we've got a lot of work to do, and changes that are going to have to happen that are going to require the Medicaid agency to do a lot of work. And so in thinking through our structure and how other states are structured right now, what we brought on a consultant to help us with this, because there's no way we could implement 9 different final rules without some assistance. So we have a consultant on board right now that is reviewing the requirements, the federal requirements, looking at other states and their structures, and then, provide some recommendations about what Kentucky to do. What is kind of the recommended best course for Kentucky? We can't do that without your all's input, though. Please understand that this isn't about us creating something and telling you what it's going to be. We really will be seeking your all's feedback. And I think what we're asking is just to please, as we engage you on this process, is to really think about what's best for Kentucky and our structure. We're going to be looking at things like agenda items that cross multiple TACs, trying to reduce maybe some duplication. What are the areas that really we need to be at the table and discussing, and is there a different way to approach it? So, but the really kind of important thing to understand about the MAC is that starting in July next year, 10% of the MAC has to be members that are on the back. So we have to get the back membership up and running, and then 10% of those have to be on the MAC. So when you're talking about our current MAC structure and how many members we have on our current MAC, you're talking about bringing on a required minimum of 10% by July next year. I think we just have to think about, for Kentucky, what does the overall MAC look like and the representatives that are on it, and what kind of changes are going to be necessary for that. The other kind of, I think, really impactful thing here are the terms and the ability to serve consecutively. So the federal law is very clear that you can only have one term, and the term length can be determined by the state. So that's something we'll be discussing with you all. But members can't serve consecutively beyond that. So, where we have had a lot of members on our MAC serve lots of consecutive terms, this is going to be a major change for us. And when you think about having to have memberships across 17 TACs and then also have membership on the MAC, again, is where we really need to talk about our structure and what works best for Kentucky, because finding enough providers willing to participate, finding enough members willing to participate, because we have members that serve on several of the TACs as well. We have to really think about what our resource limitations are when it comes to the number of people that are eligible or even interested in serving. We'll have to start submitting an annual report to CMS about the MAC activities. Already we have a recommendation process, so that's something we'll have to report to CMS too, about recommendations that come from the advisory committees, and that how the Medicaid state agency has responded to those. I think where we want to move to is just making this as collaborative as possible. We want providers and members to feel like they're engaging and they're being listened to, and that we are taking the recommendations into consideration. And so to do that, again, just may mean that we might have to sort of change the structure that we currently have today. And so you know, again, the thing here, sorry, let me go back. The kind of the roadmap that we're seeking right now is, we've been doing a gap analysis. Our consultant is looking at best practices across the states, nationally. And then we plan a lot of engagement with you all, with the rest of the TAC members, with the MAC members, with providers in general. So we're going to be doing a lot of just sort of surveys, or we might hold town halls or something just to get some engagement around a discussion of what it's going to look like for Kentucky. We do have to do a state plan amendment for this. And so we've, again, have to kind of, in the next couple of months, probably 3 to 4 months, really figure out what is Kentucky's structure going to look like. And then so we can move through the process of getting everything set up. We are concerned about trying to be in compliance by July next year, especially for a state that doesn't already have a beneficiary advisory council. So it's going to be a very heavy lift for us. So just kind of wanted to put it on your all's horizon, letting you know what's going on, and just hoping that you know, we have really great conversations. It's going to mean change, and so we have to acknowledge that and be willing to work through that together.
Thank you for that update. I feel like you should apologize for the work that creates for your team, or at least extend sympathy. All right, is there any other business from other committee members? All right, hearing none, are there any recommendations for the MAC out of this meeting today?
I don't think I've heard of any other than just reminders.
All right. Well,
Stephanie.
Yes, Erin.
I'm sorry. I did want to let you know at the last meeting, I believe Barry had requested that the MCOs provide the primary care provider change forms. We've got those all gathered up and we'll get them out to the TAC, and we will also send them to our new members so that they have them. If you want to review them, any questions, we can add that to the agenda next month, or reach out to your rep or myself if you have questions. And I also wanted to mention I am working on the 2025 meeting dates and hope to have those out within the next week or so for approval.
Great, Amen. Thank you. If there's no further business, is there a motion to adjourn the meeting?
So moved.
Thank you, Barry.
Second.
All in favor? Thank you, Brandon. All in favor?
Aye.
All right, thank you all for your time this morning.
Thank you all.
Thank you.